Good evening, everyone. Firstly, I'd like to start with an acknowledgement of country. We extend our respect to all Aboriginal, Torres Strait Islander and Maori people, including those present today, and value the importance of their ongoing connection to land, sea, sky, and community. We pay our deepest respect to elders, past, present, and emerging, and together we restate our shared commitment to advancing Aboriginal, Torres Strait Islander, and Maori health and education as core business of the college. Well, welcome everyone, and thank you for joining tonight's webinar. It's my tremendous pleasure to chair this June session of the Evolve webinar series. I'm Peter Sainsbury. I'm a retired public health physician and worked most of my career one way and another in the New South Wales Health Service. But I'm now very happily retired, very busy, but not working in health as such, at least not very much. It's my great pleasure this evening to introduce tonight's speaker, a long-time colleague and friend, Professor Alexandra Barratt. And she'll be speaking on low-value care and climate change. Alex Barratt, MBBS, MPH, and a PhD, is an epidemiologist and professor of public health at the University of Sydney, and she's participated in a wide range of health services research over the last 25 years, including many projects on the benefits and harms of screening for breast and prostate cancer. She's a lead investigator of Wiser Healthcare, a research collaboration to reduce medical overuse, including overtesting, overdiagnosis, and overtreatment. She's leading a new stream of work within this collaboration to investigate and reduce the carbon footprint of healthcare while improving patient outcomes. There's a long-standing interest in promoting science to the community and has won 2 Australian Museum Eureka Prizes for her work in science communication. No surprise at all to me. I must say it's been an outstanding aspect of Alex's work. She's an Australian Museum Eureka Prize ambassador. So Alex, perhaps you can start by telling us what do we know about low value care? Where do we start in all of this?
Thanks, Peter. Thanks very much. And good evening, everybody. Thank you to the college for the opportunity to talk tonight about this area. I think it's really, really important. And probably many of the people, all of the people who are tuned in tonight will already know quite a bit about low value care because this is the raison d'etre of this initiative of the college, which is fantastic. And, you know, hats off to the college for doing it. It's really brilliant because it's so important. And I think I'm just delighted to have an opportunity to talk to people about yet another reason for trying to reduce low value care and shift those resources to high value care. So I'm going to talk about this, what I think is a really crucial connection between low value care and climate change. And I will answer your question, Peter, but I just want to first acknowledge all of my colleagues. I'm certainly not an expert in carbon footprinting or climate change. I'm on an extremely steep learning curve, and I want to really thank my colleagues, especially Forbes McGain and Scott McAllister, who've taught me so much about this new area in the last couple of years. And all the other colleagues at Wiser Healthcare, you can see some of them listed there. So low value care, what do we know about it? We know that that's sort of care that produces little or no benefit to patients. And it's a real problem for health systems around the world. And it sort of shows up as over-testing, over-diagnosis, and over-treatment, amongst other manifestations. Over-testing is where it all starts, and that then often starts a cascade of clinical events. So this is just a selection of a few ads that are constantly encouraging us all to get tested, to test everything from our PSA level to our whole genome. And while a lot of tests and appropriately targeted tests are really important to high quality clinical care, often the emphasis is gets out of whack and we end up doing a whole lot of tests that are not well targeted and don't actually deliver the benefits that we hope for. Here's an example of that, vitamin D testing, and I'll come back to this later on, but just to suffice to say that vitamin D testing is a bit of a poster child for inappropriate testing. Some years back, efforts were made to curtail vitamin D testing, which was costing at that time more than $150 million a year to Medicare, by changing the indications and changing the MBS item numbers. And that did work, and there was a substantial drop in vitamin D testing in the following years. But as I said, I'll come back to that later. The area of work that I've been doing really is on overdiagnosis, and this is one example of how overdiagnosis has seen the medicalization of all kind of aspects of what used to be normal life, everything from ADHD to dementia. And we know now that overdiagnosis is really widespread, and that's the detection of conditions that actually are really there, like according to a microscope or to the criteria, the diagnostic criteria for the condition, those are met, but that diagnosis delivers no benefit to the patient. And that can happen because we get very sophisticated new tests that can see things that we couldn't see in years past, or because the diagnostic criteria for a condition are expanded over time. Polycystic ovarian syndrome, gestational diabetes are examples of that. Some of my work has been looking at the overdiagnosis of cancer, and people will probably be familiar with Korea's epidemic of thyroid cancer, which saw a 15-fold increase in the number of thyroid cancers in that country. In Australia, we know from estimates here that there is considerable overdiagnosis of a range of cancers, including thyroid cancer, but also kidney cancer, melanoma, prostate cancer, and breast cancer. So those are some of the areas of low value care. A recent paper by Jeff Braithwaite and Paul Glasziou looked at how we could try to make system-wide changes that would reduce low value care. And they helpfully came up with these three numbers, 60, 30, 10. And that breaks down into 60%, which is effective care. That's the care that we really want to keep, the care that's very valuable to all of us. 30%, which is wasteful, duplicative, or low value care. And about 10%, which is actually harmful. So that's the iatrogenic consequences of interaction with the health system that it obviously would be desirable to avoid. So that's kind of where we stand at the moment with low value care. And we know that it's really important to try to reduce it. And there have been initiatives like Choosing Wisely and Evolve to do that. But I think we could probably all agree there's a long way to go.
So, Alex, before we move on to talking about low value care and climate change, I'd just be interested to know, I mean, your career has had sort of the quiver of your career has got quite a few arrows in it, you know, and around breast cancer and information to women about breast cancer screening. And more recently, you've been involved with an advocate for abortion reform, legalizing abortion in New South Wales, and all sorts of things that I briefly. How did you get involved in low value care? What pushed you in this direction? What was it?
It was two things. First is I'm first and foremost a public health physician. That's my training. My PhD is in epidemiology, but I did a master's of public health. And so I see the world through the lens of public health. And I think all of us really value high value care. And you know, I've been personally touched by this, and I'm deeply grateful to medical colleagues who have effectively saved the life of one of my children. So I don't want anyone to feel that I'm criticizing medicine. It's because I value the high value care that medicine delivers that I feel quite passionate about low value care. And ultimately, it's an issue of social justice, because low value care means care that's delivered without any benefit. And that necessarily means that the resources in the health system have to then be spread over more people, both the people who are gaining no benefit from it, but also the people who really need high value care. So in order to kind of conserve our resources for where they can do the most good, we need to reduce the amount of low value and no value care. So that's probably the driving force for me.
That's really interesting. As you know, I'm fairly active in the climate and environmental movement, and my interest, sure, it's a health interest, but that's not what drives me. Exactly what you just said. I'm driven by an issue of social justice around all of this. But that's interesting that you'd say that. So moving on to the core topic then of tonight's seminar. So what do we know about the relationship between climate change and health? And then we'll move on to climate change and low value care. So climate change and health, where are we with that?
Well, I think I probably don't need to tell people that we're in a fairly catastrophic place. It's an emergency, and my thanks to Lynn Madden for sharing this fabulous photograph with me that was taken during the bushfire crisis. If anything made us aware in Australia that there was a climate emergency, I guess it was the fires at the beginning of 2020. This cloud of bushfire smoke is so big that, as in these photographs that Lynn took also, and the one in the middle from the New South Wales Rural Fire Service, these clouds are so big that they actually generate their own weather systems. And I just put that there as a reminder of the fact that we do, in fact, face a climate emergency. And we know that this has is already causing health impacts. So heat stress, dehydration, severe weather events, changes to vector-borne diseases. We've certainly had our fair share of that in the last 12 months. Thunderstorm asthma, air pollution, and its impacts on heart disease risk. So there are lots and lots and lots of ways in which climate change is already impacting health. And we know that that will continue. So we know that we need to do something about it. This is a paper from the MJA a couple of years ago, but it comes from the work of the Intergovernmental Panel on Climate Change. This red line here, this shows what will happen in terms of global temperature increase if we do nothing, if we continue business as usual. And that is clearly at around 4 degrees warming by the end of this century. That is clearly a scenario that none of us want to be in. Unfortunately, this one here, which is the best case scenario, would have required stopping emissions at the 2013 level, which didn't happen. So we are hoping that we're going to be able to change things so that emissions stabilise and we can be on track for a 2 degree at most warming. So we know that it's bad for health, but we also know that climate change is really bad for the planet. And we know that it's time to act. And I think what's really been heartening to me and gives me a feeling of considerable optimism is that there have been initiatives in the last 12 months that have been really encouraging. So this is the joint statement from the Doctors for the Environment and the AMA, both calling for the need to not only recognise that there's a climate emergency, but to do something about it in health. Because the health sector, like all other sectors, has to reduce its footprint. And so their ambition is that we get to a zero carbon health system by 2040, with an interim emission target of an 80% reduction by 2030, which is, I think, fantastic. It's a wonderful ambition, but it is going to be a challenge. And so that's really the call to action. Now the question is, how do we actually do that? And I think that's now going to be the challenging part. So I'll just show you this. This is some information from NHS England. So the NHS has really been a global leader in this area, which is really inspiring to look at what they've been able to do. So since 2008, they have had the Sustainable Development Unit, and that has enabled them to put in place changes that have reduced the carbon emissions of the NHS. In fact, this paper by Tennyson in 2020, I think it was published, 2021, showed that they had reduced their footprint by 26% over 1990 levels, since 1990, which is really impressive effort. So I guess that charts the course for us, and that's where we have to go. The challenge is going to be, how do we get there?
Well, that is indeed the challenge. I hope you're not going to leave us there, Alex. I mean, you're dead right. The challenge is how we're going to get there. And I think there's still many of our colleagues, not just in our college, but in other colleges, who, for the most part, I suspect most doctors are now aware that climate change is an issue and that it's a serious health issue. But I suspect that there's many of our colleagues that don't realise how the health system is a significant contributor to global carbon emissions, and very much so still in Australia. And I mean, there's a real sort of anomaly there, that here we are dedicated to improving people's lives and trying to stave off premature mortality and so on, and yet we are significantly contributing to climate change with the emissions we make. So we know that's the same as other sectors. So what are we going to do if we want to reduce our emissions by 80% by 2030? How are we going to get there?
Yeah, well, it's a very challenging ambition, and yeah, we do know some things. I think, but we're pretty light on for the evidence base about how we're going to do this without adversely impacting the quality of care. And so that, I think, will be the real challenge. So this is some more data from that paper that I just showed. Up here in this top left-hand corner is the total footprint of the NHS. And you can see this decline over time, which, as I said, is really impressive. But there's a couple of things to notice about this. So this is the total footprint. Over here, this is the carbon emissions per patient encounter, inpatient encounter. And you can see that that has come down quite steeply. So that's great, because that means that for every admission, the amount of carbon emissions that have been generated for that admission has been significantly and steadily reducing. But that isn't reflected in the total emissions. And the reason for that is because while emissions per patient have gone down, the number of patients that the NHS has been seeing has been increasing. And I think we can expect that to continue, because we were just talking about the health consequences of climate change. So we know that there are two tasks really before the health system. The first is to adapt to the new climate. And so there will be people presenting with heat stress, with more heart disease because of air pollution, and changes in infectious diseases and all the other impacts that we can expect with the change to the environment. And so not only are we going to have to deal with the fact that we need to reduce emissions, but we're going to need to do that at a time when the number of people requiring healthcare is going to be increasing. So first of all, the sector will need to adapt to that increased burden. And secondly, we'll need to mitigate its own footprint. And as you said, Peter, the health sector has a carbon footprint, just like all other sectors. Globally, it's about 4 to 5% of total emissions. In Australia, we're a bit worse than that. We're about 7% of the national carbon footprint is coming from healthcare. And so that's the real challenge then, is how do we reduce that? Another piece of information that is really helpful from this analysis by Tennyson et al. Is that they show that over time, there have been sort of different phases in this reduction in the footprint. So initially, this started from 1990. Initially, there were changes that were driven by getting hospitals off coal and gas, so that the what's called scope 1 emissions, or the emissions that are released directly on site, those were reduced by no longer using those sources of energy. Also, there was a shift away from chlorofluorocarbons in metered dose inhalers, and that helped as well because they have their own footprint. And then there was this period of flatness, which really was reflected by reflective of increased investment in the NHS and an increase in the amount of care delivered. And then there has been this late stage decline again in the footprint of the NHS. And that reflects the fact that the whole of the UK has very largely decarbonised their electricity grid. So by doing that, they've been able to reduce their emissions through the supply chain. So that because they not only use less coal and gas on site, also all the things that are being supplied to them are benefiting from the fact that the UK electricity grid has been decarbonised. So I think that gives us some clues about what we need to do here. But the other thing to notice is it's only taken them down that far. So it's reduced the footprint by 25%. Obviously, there's a long way to go between 25% and 80%. And that is really where we're going to have to face the fact that clinical care itself is going to need to change. So this really just shows the breakdown of the different sectors. And you can see again that what has driven this change is here the drop in energy in buildings. You can see it goes down like this. And also from improvements in water and waste, you can see that sector has come down quite a lot. Anesthetic gases and metered dose inhalers, as I mentioned early on, there was a big reduction in that. But many of these areas, like medical equipment, pharmaceuticals and chemicals, and all sorts of other things that happen in hospital care, patient travel, for example, many of these things have not come down. And these data, that was a graphical representation of what's shown here. So for example, you can see oil, scope 1 and 3, and coal, scope 1 and 3. That's, as I was saying, the energy that is used in hospitals to power them, but also in the supply chain. And you can see that that's come down from 1.74 megatons back in 1990 to a tiny fraction, 0.02. But lots of other things haven't changed, and many of the components I've highlighted there, all the things that have changed. And it's really about water and waste and recycling and energy supply. But many of the things that are actually part and parcel of clinical care have not actually changed at all. So medical instruments, for example, hasn't changed, and lots of other things, commissioned care, travel, etc. So that's, I think, where we are going to have to not only do all those things, which are really, really important to reduce the footprint of what actually happens in hospitals by greening our hospitals, improving waste and recycling, etc. All of that is really important. But that's still going to leave us with this big chunk. And we estimate, I've estimated, and other people have too, that about 50 or 60% of the footprint of healthcare is actually coming from clinical care itself, not from all that buildings, what you might call the buildings, electricity and gas. So that's where we're going to see that reduction between 25% and 80% is we're going to have to change the models of care. And this is really what brings these two things together. Because as I said before, what we don't want to do is sacrifice or compromise the quality of care. And to do that, we really are going to have to tackle, and that's why it's so important, things like Evolve and choosing wisely these initiatives which can help us to reduce low value care, because that is one thing that we can do that we know will not adversely affect the quality of patient care. So if we can get rid of the 10% that's harmful, and we can get rid of the 30% that's waste, duplicative and low value care, then we'll be a good way towards reaching that target of 80% towards 2030. But of course, we will, it's been challenging to reduce low value care. And so what I'm hoping is some of the work that we're doing is sort of doubly beneficial, because it helps us to measure the carbon footprint of things that are high value, so that we can identify the carbon hotspots and replace them with low carbon alternatives, but also provides more information about the footprint, the carbon footprint of what happens in clinical care. And perhaps that will help fuel, like energize the efforts to reduce low value care.
Yeah, I honestly, again, talking from experience, Alex, as you point out, things like the power and we use to heat and cool and move around, it's what people first think about. But in actual fact, the engineers, for the most part, in my experience, have done a pretty good job, or have been doing a pretty good job, not just beyond the healthcare system, but within it. If you talk to most engineers in health services these days, they've been working on reducing energy use and emissions and water use and one thing or another, not because they particularly care about health, they might, but because they've been looking to save money and do things more efficiently.
Exactly.
But the difficulty is getting others in the hospital managers and clinicians, to actually, as you said a few moments ago, start focusing on changing models of care. And I think that last slide you showed with the sort of, get rid of the 10%, get rid of the 30%, and you've got a lot more resources for the 60%. I think that makes that point in a sense of people can see the clear sort of common sense of that approach. I think it's a great slide, that. So how are we going to do it, though? What are we going to do to change the models of care, to get rid of the harmful care and the low value care? Where do we go? Because we haven't got much time.
No, we haven't got much time.
I don't mean this evening, I mean to reduce our...
Probably not going to do it this evening, but yeah, so there is this concept called the triple bottom line, which I think is enormously helpful. It's kind of for us, I think, going to be kind of win-win-win. And so you just mentioned that saving money, or maybe not so much saving money, but being able to direct the financial resources to where they're going to do the most good. That's a powerful motivator for people who run all sorts of clinical services, and understandably, because we don't want to waste financial resources. So that's one element. The other element is the environmental impact, and it's really important that we can measure that, because we won't know how we're tracking unless we can measure that. So I think one of the things that we do need in Australia is an equivalent of the Sustainable Development Unit, sort of a healthcare sustainability unit for the nation, so that we can start measuring things and tracking how we're going in terms of reducing our emissions. And then, so the triple bottom line was a term that was coined 25 years ago. It's actually a term from business. And people who have been working in business will recognize that it's meant to quantify the social, economic, and environmental impacts of a business activity. And I've been thinking about that in healthcare, thinking about the environmental impacts, the economic impacts, and the social is really the health benefit or the health gain. So ideally what we want to do is reduce the low value care, so that by doing things, less of some things that we know are low value care, we can maintain that element of health outcome for the amount of, but at the same time reduce the cost of it and reduce the carbon emission. And so I'll give you an example. So this is some work that we did over the last couple of years, measuring the carbon footprint of common pathology tests. The rationale for doing this was that it hadn't been done in the world. There are different ways of measuring the carbon footprint of things like health system or particular health interventions, whether that be a test or a drug or a device or a surgical procedure. We have got a few big picture studies like the one by Aranima Malik and colleagues that quantified the overall size of the health system, which is really important and useful and valuable. But we also need to know what's the carbon emissions from individual items of care, because we need to know that so that it can inform clinical practice, so that if we do change clinical care, we know that this particular item has got a big carbon footprint, whereas this one doesn't, for example. So that's why we did this. We used a method called life cycle analysis. And life cycle analysis is, it's a really important tool in measuring carbon emissions. And what it does is give you a way of estimating the total environmental impact of a specific thing. So many life cycle analyses have been conducted in the last 25 years. There are international standards for how to do it, but they've mostly been done in building and agriculture, transport, those kind of sectors. And very few have been done in healthcare. Like, you can measure them in a few dozens. There's really very few of them. But it's called life cycle because it takes a particular good or service from the point of acquiring the raw materials through the process of manufacturing and distribution and use, and then disposal, which is referred to in these kind of studies as end-of-life care, and was initially enormously confusing to me because end-of-life care to me has a totally separate meaning. So just a word of warning, when you're reading these things, it's got nothing to do with end-of-life care like we think about. It's end-of-life as in, what are you going to do? You're going to incinerate it, you're going to bury it, or how are you going to dispose of this thing? So we use this approach, life cycle assessment, to quantify the carbon footprint of common pathology tests. Now, I need to stop here and just make a kind of methodological note. So there are two ways that you can do this. You can either do it by what's called economic input-output analysis, and that's what's used for the big sector footprints. So, for example, that paper by Malik et al. That estimated that the footprint of Australian healthcare was 7%. That was mostly an economic input-output analysis. That's how many life cycle analyses are done in other sectors, which is fine because there is generally a relationship between the dollars spent and the carbon emissions. And in other sectors of the economy, supply and demand drive a lot of stuff, so that makes sense. Whereas in healthcare, it's not a perfect market, and we wouldn't want it to be a perfect market. So you can't, so that sort of thinking about supply and demand doesn't always hold. And more importantly, the assumption that dollars spent is related proportionally to the carbon emissions doesn't always hold. So a simple example, if you think about if you're trying to measure the carbon footprint of a particular drug, you can't just use the economic value of that, because if you do, you will wind up with an estimate of the carbon emission of X. But then once the drug comes off patent, it's going to be, suddenly it's going to look as though the carbon emissions are much smaller, simply because the drug has become much cheaper. But that's just because it's come off patent. The actual processing and the materials used and everything haven't changed at all. So to allow for that in healthcare, a number of groups around the world are using this other method, which is still a life cycle assessment, but it's called process-based life cycle. And what it does is it tracks through all of the processes that are used in that whole life cycle and estimating the emissions that way. So for pathology tests, you have to think about, well, what are all the materials, the things that are used, and the energy that is consumed in order to do a pathology test. So you need to think about, well, we have to take the blood, we need gloves, we need a cotton swab, we need a syringe, you need the tube that it's that it will be collected in, then in the lab, the machine will use energy that needs to be accounted for as well. There's the packaging that the chemicals come in, there's the chemicals themselves, etc., etc. So it's a long and complicated process. But there are, as I said, there are international standards, and the methods for doing it are well established now. So one of the team on this is an environmental scientist who did this work. He had done a lot of life cycle analyses outside of health, and he has now done quite a few inside of health. And this is what we estimated. So basically, roughly speaking, one blood test has a carbon emission of about 100 grams of CO2 equivalent emitted, which is not a lot. But then you have to also remember that we do about 500 million pathology tests a year in Australia. So while for each individual test, it's not very much, if you add them up, it's an enormous footprint. Which brings me back to vitamin D. So now that we have done this work, we can use that to quantify what is the carbon footprint of different types of pathology testing. So vitamin D testing, as I said, is an example of low value care. There was some work done a few years ago to look at what proportion of vitamin D tests in Australia could be considered inappropriate, in the sense that the people tested did not meet any of the indications for the test according to the MBS criteria. And that work was done and came to the surprising finding that when the new MBS items were introduced in 2014, the indications were actually changed and narrowed to restrict the use, with the aim of restricting vitamin D testing to be targeted to people who were at high risk of vitamin D deficiency. But yet, when that happened, the proportion of people not meeting those new indications actually increased. So while the total number of tests declined, the proportion of people who didn't meet those criteria, those indications, increased up to 76% from 71%. So we know that about 76% of tests in Australia currently being done do not meet any of the MBS criteria and could be considered inappropriate. There have been other studies around the world that have come to a range of different estimates, between 30% and 90% of vitamin D tests being inappropriate or unnecessary. What surprised me was that, even knowing this, and this was published in the MJA in 2020, and it was pointed out that the tests were on the rise again in those data were to the end of 2019. We looked at it last year, and we got the vitamin D tests from the MBS item numbers, which are publicly available. Oops, sorry, wrong way. And they went up even again more. So the dotted line here shows the cumulative total of vitamin D tests in 2018-19 averaged, and this is what happened in 2020. You can see these are the monthly figures. So you can see there was a little dip in April where the number of tests went down because we all went into lockdown and pretty much nothing happened. But then the monthly tests recovered, and by the end of the year, we actually had more vitamin D tests done last year than in preceding years. And this is the total number of tests. So that's 4.5 million vitamin D tests for the Australian population. So it works out to about 1 vitamin D test for every 5 adults. So we did a little bit of work to try and work out what would that actually be costing. And based on so you can get the cost from the MBS, and it works out that the total vitamin D tests in 2020 was at a cost of $134 million. And if you take 75% or 76% of that, that's still over $100 million on unnecessary or inappropriate vitamin D tests. We can also, from our previous work out the carbon footprint of those tests. And very conservatively, it is between 37,000 and 55,000 kilograms of CO2 emitted. That's for all tests, and between 30,000 and 43,000 kilograms just for the inappropriate tests. That's equivalent to driving a standard passenger car between 200 and 300,000 kilometers just for the inappropriate tests. So that's not perhaps all that much, but that's just one test. And as I said before, we do 500 million pathology tests a year. We know that from other research that between 10 and 40% of those tests are low value care. So if you start to, imagine the size of the footprint of this, not only is it not improving health, not only is it costing us hundreds of millions of dollars, but it's also contributing to our footprint. So my hope is that by quantifying some of these things, and can I just say, this is not meant to be critical of people who are working in pathology. There may be some pathologists in this webinar, and can I just say that pathology labs have actually done a lot of work over the recent past in trying to green their environment. So they have put in place things to recycle, to reuse, to reduce their energy consumption. They have done all the right things. But the problem still is that there are too many low value tests being ordered. So that's where we really need to target these efforts. Just to give you another example.
So Alex, can I just jump in for a sec? It'd be good to get to questions in about 4 or 5 minutes, if that's okay. We've got some questions. Okay.
Great. So I just did one other example. So this is one of the Choosing Wisely recommendations. Don't routinely order breast MRI in new breast cancer patients. And just to cut to the chase, using, so the thing about MRI compared to previous types of imaging is it has a much bigger footprint, mostly because it uses a lot more electricity. So in this example, I worked it through. So what would happen if we actually followed that recommendation and didn't order MRI in so many patients? And you can get estimates from the research about what proportion of patients do get an MRI and what that could be reduced down to. So I did some calculations. I worked it out using both an economic input-output approach and using a process approach. And to cut to the chase, if we could actually implement that recommendation appropriately, then that would result in many thousands of kilograms of CO2 emissions reduced every year. And you can see that that saving equates to many, many kilometers in a passenger car. And that is just an example of how there, as I said before, there are some hotspots, and we know that we need to target these hotspots. So apart from doing high value care and reducing low value care, we also need to think really hard about how do we reduce these hotspots. And clearly getting all of us, getting the grid off fossil fuels and onto renewables is going to be really important in this, because that would be one way that we could really make a major impact on reducing the footprint of new forms of imaging like MRI. So I'll just stop there and see. We should go to some questions, Peter.
Okay,
I think.
That's great. Thanks.
Yep.
Alexa, tremendous. Thank you very much, and very clearly put as well. So there's a couple of questions about vitamin D. One's quite a simple one, but important. It's in the chat, and everyone can see it's from Stuart. And he says, is his hearing at fault? Was it really $110 million wasted on vitamin D testing?
Yep, it was.
It was, Stuart. And was that total, or is that per year?
Per year.
Per year. There you go. So no, our hearing, you and me, Stuart, it was quite right. But thanks, it drives the point home. And then there's another question which was put up before you made your points about the criteria for ordering vitamin D tests. So I suspect you've answered this question when you got on to talking about the criteria basically being ignored a lot of the time. But this question in the Q&A says that vitamin D deficiency is highly associated with falls in the elderly, and falls are a significant cause of mortality and morbidity, of course. Should we test vitamin D level in patients having falls, or should we just give every patient with a fall long-term vitamin D without testing? And the questioner says, you know, have you got anything to say about the carbon footprint of this, and the cost and so on? So is there anything you want to add to what you said earlier about it's not just a question of not testing and then people, it's too expensive, it uses too much carbon, it's really going against what the recommendations are. Is there anything else you want to add to that?
Yeah, so there has been just recently some, there's a US Preventive Services Task Force recommendation on vitamin D screening, and there's also nice guidance available as well. And I think, I'm so not an expert on vitamin D and how that should be managed, but there certainly are those sort of level of guidance saying that it's actually not necessary to do the testing often. There may be an argument to just actually go direct to supplementation rather than doing testing. However, I think the literature is actually pretty unconvincing about the benefits of supplementation as well. So one of the things that kind of precipitated us looking at vitamin D in the last year was that there was a lot of information and misinformation and confusion about whether vitamin D may have a role in COVID. And so it perhaps is not surprising that vitamin D testing did go up in 2020, because there probably was some feeling that it's important to test and possibly to supplement because of the possibility that that may have been beneficial in COVID prevention or treatment. I think the trials, now that they've been done, have demonstrated that that's actually not the case. And so there isn't, goes back to where we were before, that there, except for situations where there are reasons to suspect like a high risk of vitamin D deficiency, it isn't necessary to test.
Okay. You've focused with your examples this evening on low value care in terms of testing and diagnosis. Have we got much evidence about low value care? You led into it there, but much evidence about low value care in terms of the actual treatment modalities that we use, either as doctors or elsewhere in the health service? Has much work been done around that, you know, taking everyone's temperature 3 times a day isn't very high value? Or I don't know whether that's true or not. You know, washing the sheets every day isn't very high value. Or I suppose that's not a clinical example, but I mean, has much work been done in those directions?
Yes, certainly. And I'm sure there are people on the call who'd be much more knowledgeable than me, could talk about efforts to do de-prescribing, because there are instances there, you know, there's certainly places in the health system where where there's excess prescribing, and particularly amongst older people. But I suppose what I could talk more about is the overdiagnosis, because that's really been the area that I've concentrated on. And what is really obvious from that is that, yes, overtreatment flows from overdiagnosis. So if you think, for example, we estimated that 40% of prostate cancer that's detected in Australia is overdiagnosed, which, you know, is just like mind-numbing, because I think from memory that was about 8,000 men overdiagnosed with prostate cancer every year. There's just under 20,000 prostate cancers diagnosed every year in Australia, so around about 19,000 a year at the moment. So if you accept that estimate, and it's not dissimilar from estimates in other countries, say 8,000 men overdiagnosed with prostate cancer every year, they all go through treatment. And so the harms and the cost and the footprint of all of that over treatment has got to be significant.
Mm.
Certainly some work has been done on the costs. And one of the things that we are looking at doing now is we're trying to do this sort of footprinting of what you might call the building blocks. So my colleague Scott McAllister, for his PhD, is looking at these sort of what we're calling building blocks. So it's like the footprint of pathology testing, the footprint of imaging, and then we can start to put together the footprint of whole pathways of care. So prostate cancer might be a good example. So we know that there's a lot of overdiagnosis. We know that there's considerable overtreatment of prostate cancer. But if we can footprint those building blocks, then we will be able to assemble those elements and be able to build better models of the cost and the footprint of whole pathways of care. Does that make sense?
Yeah, I must say that the slide you showed from the NHS from, I can't remember, whatever, 2000 to 2019, that showed that sort of stacked histogram with how energy had fallen, but the actual things that we do to patients hadn't changed much at all. I thought that was a very telling slide as well, demonstrating how much room we have there to try and start making some reductions. And as you just pointed out, that it isn't just about saving either cost or saving emissions, it's about improving care.
Exactly.
And improving care,
exactly.
in my experience, for clinicians, means improving work satisfaction as well. There's a payoff for individuals.
Exactly. And I think that's been one of the things that I've really recognized in the overdiagnosis research is, you know, if you imagine a waiting room full of people who've been overdiagnosed, whether it's with PCOS or gestational diabetes or ADHD or prostate cancer, some of those patients don't need to be there. And that is putting an enormous pressure on our services. You know, it's also about the well-being of health professionals, because the system is being, and there have been some GPs who've written really heartbreakingly about this, about the fact that they're trying so hard to do a good job, but they are so busy doing, and I have to say, Peter, public health is somewhat responsible for this. They're so busy doing all their, you know, risk factor screening and health checks and health prevention, you know, health promotion things, that they don't actually have time and energy left to care for the people who are really sick and who really need that care. So yeah, like, you know, mea culpa too. I think we all need to get our house in order.
Actually, the next question, it leads on. In fact, it's a question I was wanting to ask myself, but this question's tremendous. Again, it's to everyone. So Nicole says, given that we spend so much time in medicine medicalizing symptoms of an unhealthy society, how can we shift the culture to a lifestyle medicine-based approach, focusing on the causes of the causes of chronic disease, rather than treating and managing reversible chronic disease with carbon-intensive interventions? Because, I mean, we're a college of physicians of one sort or another, and I'm conscious that physicians do stuff in the rooms and so on, but I think there's a tendency for us to think about what goes on in hospitals. But out there's loads of GPs, and their footprint and costs are not negligible, and there's public health, as you say. So some of this changed model of care must be, as Nicole says, changing from just thinking about the tests we do in hospital and the treatment we do in hospital to lifestyles, to social determinants, to the causes of the causes.
Yeah.
Any comment? You told us at the beginning you were a public health physician. This was what drove you along.
Yeah, well, I think there are a few things that we need to do. The first is we all need to advocate. You know, that's one of our jobs as doctors, is to advocate. So we all need to advocate for, it's really hard in this country, but for getting off coal, getting off gas, and for decarbonising the electricity grid. You know, that will go a long way. So that's a no-brainer. We really need to do that. But also, one of the, you know, really fundamentals of public health is the importance of primary care. And hospitals have a much bigger footprint than do primary care practices. So part of what needs to happen is getting the hospital care down to the minimum level possible so that hospitals do what we need hospitals to do, and that we make the most of our primary healthcare sector, because that's good for health, it's good, it's good finances, and it also has a smaller carbon footprint. But that said, whether you're working as a doctor in primary care or in hospitals, there are hotspots. And hotspots to watch out for are in primary care, pharmaceuticals. So the footprint of pharmaceuticals is considerable. So that goes to the issue of not over-prescribing and making efforts to follow the Evolve guidance and choosing wisely to reduce prescribing. Another hotspot in primary care, which is really important, is metered dose inhalers. They have a really big footprint. They can be, so when it's clinically appropriate, to replace them with dry powder inhalers, and that's not always going to be clinically possible or appropriate, but where it is, that has a much smaller footprint. And for people in hospital care, one of the really big footprints, and it's just astonishing, is anaesthetic.
Last point, Alex, we better make this your last point. Okay, carry on.
Anaesthetics. Anaesthetics themselves are really potent greenhouse gases, and hospitals vent them into the atmosphere. So that's a really important area that needs to change, is to shift as rapidly as possible off those inhalational anaesthetics like desflurane, but also nitrous oxide. And so that will be a challenge, but that will be something that could really make a big difference.
Okay, great. Well, Alex, when I got an email saying, would you be interested in sort of facilitating a session with Alex, I hit reply immediately. I knew I would be, and it's been a great session. So on behalf of everyone that's been taking part this evening, just want to thank you, Professor Alexandra Barratt, for a tremendous presentation and loads of information, but really clearly presented. So thank you very much indeed.
Thank you, Peter, for agreeing to facilitate it. Much appreciated.